All right, today's topic again, airway failure or pending airway failure. In this scenario, we're going to use the same scenario I used in the last video, but we're going to do some different techniques and different ideas. Maybe challenge your system or challenge your guys' ideas of some things that you can use that maybe are non-conventional, but maybe might be a little more appropriate, a little more beneficial for your patient. So again, dispatch on difficulty breathing. You got an adult male. History of CHF and COPD. Family can only tell you they has CHF, COPD, has high blood pressure. Individuals tachypnic about 80 breaths a minute. Can only speak 1 to 2 word sentences. Very, very anxious, pale upon presentation. So the first thing I'm going to do here is I'm going to apply nasal end tidal. And CPAP right off the get-go. And while I'm doing this, my partner's going to put them on the monitor. We're going to run our first set of full vitals. So let's see what we see here. Initial SpO2 is 81%. Respirations are about 40 a minute. Heart rate's in the 130s. It's normal sinus, or check sinus tach on the monitor. Do a 12 lead just because you're curious. 12 lead's negative for any ST abnormalities. No acute findings are noted. CPAP's in place. I look at my end tidal waveform, which is not being displayed.
Tapping on it. Change that timing again. That's respiratory speed. There we go. Just exit. There we go.
All right. End tidal 25 at a rate. And it looks like we have no airway restriction. So I'm ruling out pretty quickly COPD exacerbation. So my thought process now switches right to CHF. I'm going to listen to the lung sounds. They're diminished throughout, unable to differentiate between clear versus rhonchi or rales versus expiratory or inspiratory wheezing due to the diminished lung sounds and environmental noises. So CPAP's in place. I got a PEEP setting originally of 5. I'm going to increase that to 7.5 and see if I have any changes. I'm also going to establish an IV for IV access. Listen to lung sounds again, still the same, still diminished throughout. The patient does have some slight relief with CPAP being placed. I do see a slight decrease in heart rate, a slight increase in SpO2, which is both are suspected. Secondary exam, I have no additional findings. I notice with CPAP here at 7.5, I still have a waveform that tells me there's no airway restrictions. I do have a slight increase in end tidal values. I also have a decrease in respiratory rate with some increase in unresponsiveness. Patient will open his eyes when being communicated with, but will not follow any commands. Respirations went from in the 40s to about 8 a minute, so I have a suspicion of pending airway failure. I'm going to move to assisting ventilations here with a BVM that I'm also going to add a PEEP valve to. So PEEP valve's applied, 7.5 is dialed in to match what the CPAP was. Patient's going to take one more respiration in. CPAP's been discontinued. BVM is now in place. Still have PEEP, so I still have airway recruitment and the ability to splint open the lower airways. So we're going to ventilate this guy, assist in his ventilations at a rate of 8, and then probably give him some full mandatory ventilations to equal about a 10 to 12 to 15 range for respiratory rate here. IV's been established. I'm going to have my partner ventilate him at the rate I described. with this current technique, keeping the CPAP mask in place, it is secured, there's no air leaks, and it also frees up my hands. So I'm going to draw up my paralytics because my suspicion is I'm going to need to eventually get a secure airway on this individual. So we'll ventilate for a while. I'll get my supplies all ready, I get medication drawn up, and before we'll do one more set of vital checks. I grab our simple vent circuit. I apply PEEP of 7.5 again. On inspiration, he gets a full breath. I'm going to discontinue the BVM. I'm going to place my ventilator in place of the BVM. Still have PEEP. Now I have a guaranteed tidal volume and a respiratory rate, so I can guarantee minute volumes. We're going to leave this individual in a high followers position due to the fact that I do believe that it's CHF exacerbation. I don't want to worsen that until I absolutely have to. Rechecking vitals here. Heart rate's down a little bit. We're in the 118s, still sinus tach on the monitor. SpO2 has improved drastically, all the way up to 95%. N-title's at 36, again with no airway restriction noted. And blood pressure is 153/73. So I had an improvement in oxygenation from the initial step, performing pre-oxygenation prior to the intubation step, which is what the ultimate goal is going to be. So I got everything prepared. I got my tube prepared. I got direct blade number 3 straight. I have end title prepared. I have a tube holder. I have my backup airway. I have King Vision available. I have everything that I need. Suction is also available. We're going to push our paralytics. Should have the desired response. For this scenario, I chose rocuronium and etomidate. Both weight-based and appropriate doses. I get the desired effect. He is chemically paralyzed and no longer has a respiratory drive, so we're providing that for him with the vent circuit that's applied. Everything's prepared and set up. I'm going to leave his nasal end tidal in place. That's going to be hooked up to a high flow oxygen source during the intubation process. I also am going to leave him in the high followers position as long as possible. When I do intubate, it's going to be at a 20% incline so that not to lay him all the way flat. I'm going to go ahead and lay into that 20%. My tube is ready. My suction is on and around my arm. I'm going to undo the mask settings here. I'm going to time it so it does give one last breath. Big breath in, big breath out. I'll watch end tidal. I got a good expiratory waveform. Discontinue that. Leave the end tidal in place. We're going to sweep his tongue. Airway's been identified. Airway's placed. Inflated. Tube end tidal is going to be placed. Ventilator circuit that was left on going to be reattached. Going to now attach the tube end tidal, since nasal end tidal will no longer be a functioning since I do have a secured airway. So plug all the things in. Respiratory rate again is 16 to 18, controlled by the vent circuit. Tidal volume is about 480. I got good rise and fall of the chest. Lung sounds are still diminished, although I'm starting to hear some air movement. We're going to recycle our blood pressures, see if anything changes on that end. Identify tube depth. Looks like it's about 25 at the teeth. Lung sounds were confirmed in all lung fields. End tidal show me a good wave and good value, so we know we're secured in the trachea. Tube is secured. Again, I'm going to raise this individual to a semi-Fowler's position to help gravity keep that fluid as low as possible. Recheck on vitals here. Heart rate's down to 101. Strong and regular rate. SpO2 is still 96%, had no decrease or no desaturation during intubation process due to the pre-oxygenation phase and the PEEP adjustment that we did prior to intubation. Blood pressure is now 144/79. End tidal is 35 with a square waveform, so I have good inspiratory and expiratory waveform. Looks like the tube is secured in place. Paralytics and sedation medication are all appropriate, and this patient would get transported to the hospital in a semi-Fowler to high Fowler's position, secured with hopefully 5-point harness, and reevaluated every 3 to 5 minutes to make sure I don't have any change in end tidal, which would maybe suspect that I'm losing my tube.